Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, the podcast heads to Oklahoma. Dr. Dale Bratzler, the University of Oklahoma's Chief COVID Officer and Interim Dean of the Hudson College of Public Health, joins Dr. Sharfstein. They discuss shutting down the university in the winter of 2020, the lasting health and economic effects of the pandemic, and the particularly severe impact on rural communities. Let's listen.
Dr. Dale Bratzler, thank you so much for joining me on Public Health on Call to talk a bit about your experience on COVID in Oklahoma.
Yeah, thank you. It's my pleasure to be here.
I think it would help maybe just to introduce yourself to our listeners. You've had quite an interesting perspective during the pandemic in a state that doesn't get a lot of attention.
Yeah, thank you. So I have had an interesting role here at the University of Oklahoma through the pandemic. Back when the pandemic started, I was the chief quality officer of our health system, which includes our 3 hospitals and our faculty of practice. And I continued to hold that role. But in June of 2020, the university president contacted me and asked me if I would serve in the role of chief COVID officer for the entire university. And then most recently, in February of this year, I was asked to assume the role of interim dean of the Hudson College of Public Health on top of everything else. And I've been my primary appointment here at the university is in public health. And I've been here at the university for the past 12 years.
So the transition from being the quality officer in the health system to suddenly being the COVID officer for the entire University of Oklahoma must have been pretty impressive. What was that like for you?
Yeah, so I was asked to come on in June of 2020 when we were just really starting to see the huge increase in the number of cases of COVID-19. We have a large undergraduate campus in Norman, Oklahoma, with about 25,000 students. And I think part of the reason the president called me and asked me to take the role was because he was getting so much advice from so many different people across our 3 campuses. And so when we first met, he asked me simply to make sure that there was sense to the policies that we put into place, and he was not going to implement any university-wide policies until they'd at least crossed my desk and I had reviewed them so that we could get some consistency of policy across 3 campuses in 3 different cities.
And what were the kinds of policies you were putting into place back then?
Well, obviously, one of the first ones was there were a lot of questions about whether we should mandate masks early in the pandemic. But that was one of the first things that I did. It wasn't necessarily the most popular thing I did, but I think it was important, particularly as we've learned more about the spread of this particular disease. We looked at all sorts of policies. I got to work very closely with the operations folks at the university about buildings, air exchanges, all the things that might reduce the spread of this particular disease. Ultimately, in 2020, we did make the decision to shut down the university and go entirely virtual, which was incredibly expensive for the university and also didn't make very many people happy. But we were just seeing widespread, infections from COVID-19 at that time. And it just made sense to go virtual at the end of 2020 as we were seeing so many cases in our state.
I know that that's not a popular thing to do in any place, but I'm imagining in Oklahoma, it was particularly controversial.
Yeah, it was. I think early in those decisions, it wasn't quite as controversial. I mean, everybody was scared of COVID-19. We had no way to prevent the disease, and we weren't giving vaccines yet. And so everybody did have concerns about it. And we saw large numbers of people in Oklahoma being hospitalized. Oklahoma did not do particularly well with the pandemic with relatively high rates of death. We still have relatively low rates of vaccination. And so we saw widespread cases. And one of the points that I made was that we were seeing large outbreaks in rural communities across our state. And so while it wasn't necessarily popular, I didn't get much pushback when we first started. But from that point forward, once we did that and then came back for the next semester and put all the policies of mitigation into place, people had gotten used to the fact that we had to have rigorous protocols for COVID-19.
Got it. Did you have a sizable group of people saying it was a bad idea, time to loosen up? Why are you so, tough? Or even, is COVID real? I mean, we've heard about that in different parts of the country. Was that part of your daily life eventually?
Yeah, absolutely. In fact, I tell people the most interesting title I got was after we implemented the mask mandate, and it was Socialist Dictator was the title. That it was actually a grandmother that sent that to me because she really felt that, the social aspects of college were so important and that we were limiting the ability of students to have that social interaction with online classes, spreading people out in classrooms, requiring masks and things like that. So it was, lots of decisions were controversial. As we progressed in the pandemic, of course, in Oklahoma, we actually had some legislative action and executive actions by our governor that limited our ability to mandate masks and do certain things to prevent the spread of the disease. So as I said, some of the policies were unpopular.
Yeah. Well, it's impressive, though, that you made it through. You've gotten promoted to lead a school of public health, no less, a program in public health. So I do want to ask you this, and then I want to talk about the future, but it doesn't sound like you were so steeped, maybe your whole professional life wasn't in public health when this all started, but what kind of appreciation have you gathered for the field since you were thrown into this role?
Yeah, so I completed my degree in public health in 1996 and have taught in public health for a number of years. I am a practicing internist, but have always appreciated public health and understood the implications. I was one of the people when we first started meeting at the university that remembered the 2003 outbreak of SARS. And so we actually were very aggressive very early because there were enough of us that remembered what happened with SARS as it spread around the world that we recognized this was not going to be simple to prevent the spread through the country. So I've always appreciated public health. I came to the university a little over 12 years ago with a primary appointment in public health. I am the chair of health administration and policy, which is my field. And our dean, who'd been here for 20 years, was promoted to provost of the campus. So he asked me to take on the role of interim dean of the College of Public Health.
Well, I guess what I'm asking is not so much your credentials. I totally believe you are well qualified for that job, but how your experience living public health in a way during the pandemic has changed your thinking about the field.
Yeah, so I think just going into public health changes your perspective around prevention of disease. Certainly in my practice of medicine, it was always the individual patient was always at the forefront. But what I quickly learned when I was in public health training and subsequently in the many different roles that I've had is that public health is really important. I kind of felt I spent a lot of my career researching certain types of infections and also adult vaccination. And I recognize that the policy changes that we made nationally around vaccination probably had far more impact with respect to patient lives than I could ever make in my private practice. And though I love private practice and seeing patients, I recognize the implications that public health has to really dramatically change outcomes in our country.
Great. Now, I know you're thinking a lot about the aftermath of COVID, not declaring it over here on the podcast, but as it's sort of receding from our, that front line of emergencies in our mind, what do you think is coming next for COVID?
Well, so I don't know. I'm not sure how we're going to define when we become, quote, endemic for COVID-19. I read a recent paper out of the University of Washington that suggested that even at endemic levels of COVID-19, it still may end up being one of the most common infectious disease causes of death going forward for many years to come. Predictions of 100,000 people in the U.S. dying each year, which is more than we typically would see from diseases like influenza and others that cause patient death. So I think we're going to be living with the consequences of COVID-19, both acute infections and consequences for patient care for a long time to come. we also know that there are a lot of people who got infected with this particular virus during the pandemic who are still struggling with long-term consequences, a variety of different syndromes that may limit their ability to do. I think we're learning more every day about some of the consequences of previously being infected with this particular virus. So I think we're going to be taking care of a lot of people for a long time who have some long-term consequences of COVID-19. Some of the interesting ones recently have been the impact on the brain, dementia, potential psychiatric disease, and others that may occur in some patients. So those are going to be difficult items to deal with for a long time to come. And then in my state in particular, I've noted that with our economist here, we've been talking about the financial implications of COVID for people, not just the economy, but for individual people who've been infected, who have lost family members, who may have some of the more severe long-term symptoms, who aren't readily available to go back to work, to do things. And I think it's had a profound impact on some families. A lot of children lost a parent through the pandemic. And I think we're going to be dealing with a lot of these financial consequences of the disease for some time to come.
We haven't talked that much about COVID in rural America on the podcast, and it sounds like you have that a little bit in mind when you say there are going to be serious financial consequences.
Yeah, I do. So I will tell you that we're in the process of doing a study right now on the death rates from COVID-19. And when we look at the death rates, we find many, many rural counties in our state that have death rates that are more than twice the statewide average of death rates by county. And I think there are a variety of reasons for that. We saw lower uptake of vaccine in some of our rural counties, but we also have an unhealthy state, a state with lots of diabetes, heart disease. We're number one for heart disease deaths, chronic lung disease, and other conditions that put people at high risk. We also know there are more elderly people. The proportion of elderly people in many of our rural communities is higher. So when we've been studying the death rate in rural communities in our state, it has been substantially higher than the statewide average for deaths in the state. And so, I think that's going to be a consequence going forward.
Yeah, and the economic impact there can be quite profound, even from just a few deaths.
Absolutely. And as you know, many hospitals now are struggling from the consequences, what's happened with COVID-19, and particularly in our state, many, many rural hospitals are just on the edge all the time of closing their doors. So it's been really difficult to maintain good healthcare availability in many rural communities.
Well, Dr. Bratzler, really appreciate your time today. Thank you for everything you did for the university and the state of Oklahoma, and wish you the best in your public health position.
Thank you. I've enjoyed it.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.